Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Hanin Faisal, your host for today's episode, and we're joined by my friend Afnan Bajaber to discuss miscellaneous disorders of the small bowel.
Think of this episode as a collection of disorders of the small intestine that don't fall neatly into one major category, all grouped together in one lecture.
Exactly, and I think we're ready to begin. Let's start with Meckel's diverticulum.
Meckel diverticulum is the most common congenital anomaly of the gastrointestinal tract, and it's a true diverticulum,
What exactly do you mean by true?
meaning it contains all layers of the bowel wall, mucosa, submucosa, muscularis, and serosa. This is usually true for congenital diverticula, unlike acquired diverticula, which are usually false and don't contain all layers.
And where exactly is Meckel's diverticulum located?
It's typically found 2 feet from the ileocecal valve on the anti-mesenteric border of the ileum.
I remember it contains ectopic tissue as well, right?
Yes, about 50% of Meckel's diverticula contain ectopic mucosa, most commonly gastric mucosa and less commonly pancreatic tissue. The gastric tissue is clinically the most important.
Let's pause for a case. A 2-year-old boy is brought to the emergency department with painless, maroon colored stools. No abdominal pain, no fever, vitals are stable. What's the mechanism?
This is classic for Meckel's diverticulum with ectopic gastric mucosa. The ectopic gastric tissue secretes acid, just like normal stomach lining would.
And that acid damages the diverticulum, right?
No, not the diverticulum itself, but the adjacent normal ileal mucosa. Remember, the diverticulum has gastric mucosa, which is already used to the acid. The adjacent normal ileal mucosa, on the other hand, lacks the protective mechanisms against acid and gets ulcerated, leading to painless bleeding.
Why is it painless?
The bleeding is due to local erosions in the mucosa, but there isn't actually any inflammation.
Ah, that makes sense. Bleeding isn't the only presentation though.
Right. Many patients are asymptomatic, and in adults, the most common presentation is intestinal obstruction, not bleeding.
How does obstruction happen?
Through intussusception, incarcerated letraise hernia, or volvulus of the small bowel,
Volvulus around what exactly?
around the fibrous band connecting the diverticulum to the interior abdominal wall.
So let's say a 28-year-old man presents with vomiting and abdominal distension, and during surgery, they find the ileum twisted around a fibrous band attached to the abdominal wall.
That would be small bowel volvulus secondary to Meckel's diverticulum.
Okay, and you also said something about letraise hernia. What's that?
Letraise hernia is when Meckel's diverticulum protrudes through any openings or defect in the abdominal wall.
Ah, so when it herniates, that part can get obstructed. Makes sense. Can we have another complication of Meckel's diverticulum other than obstruction?
For sure, you may see perforation, umbilical fistula, or Meckel's diverticulitis.
So the diverticulum can get inflamed.
Yep. Interestingly, it mimics acute appendicitis, both clinically and anatomically, so we really have to be careful when we're differentiating between them.
I'm guessing you need imaging in order to diagnose it.
Yes, imaging includes radionuclide scans, contrast studies, CT scan, and sonography.
Do you need to surgically remove it?
It depends. Symptomatic cases require resection, but if we discover it incidentally, we don't remove it.
Before we move on, there's one classic thing we can't skip with Meckel's diverticulum. You've probably noticed we said the number 2 a lot for this disease.
Yep, the classic rule of twos. It's very helpful to remember key features of Meckel's diverticulum. First of all, the incidence is about 2% and it affects males more than females with 2 to 1 ratio.
And age-wise, it usually presents at 2 years old.
Yes, remember our patient that we just discussed. Meckel's typically presents before the age of 2.
The location is also part of the rule, right?
Yes, Meckel's diverticulum is usually located 2 feet from the ileocecal valve, and the base is typically about 2 inches wide.
And the last two of our rule,
It often contains 2 types of mucosa, most commonly gastric and sometimes pancreatic tissue.
if you remember the rule of 2s, you'll be good to go, right?
Yep, I hope so.
Alright, moving on to the small bowel diverticula.
These are rare, with an incidence of less than 1%. They are more common in the jejunum than the ileum and are also usually larger in the jejunum.
Are these acquired or congenital?
These are false acquired diverticulum, meaning it's not all layers, only the mucosa and submucosa, herniating through the muscular layer. These arise from the mesenteric border, which explains why they can be hidden in the mesentery and easily missed.
How do these patients present?
They may get partial small bowel obstruction, acute diverticulitis, perforation, bleeding, duodenal dyskinesia syndrome, or malabsorption due bacterial overgrowth.
Wow, that doesn't sound like fun. So the key mechanism here is bacterial overgrowth due to intestinal status with the diverticula leading to malabsorption and inflammation and all that.
Yep, pretty much.
Okay, so that was small bowel diverticula, specifically in the duodenum and ileum. What about the duodenum? Duodenal diverticula are more common than people expect.
Yes, they're the second most common site of diverticula after the colon, with an incidence of 15 to 20%. Surprisingly, over 90% are asymptomatic.
They are also more common in females, right?
Yes, you're right.
Where are they usually located?
The majority are near the ampulla, which is the opening of the biliary and pancreatic duct, so the diverticulum bulges out of the location and projects into the pancreas. This explains many of the complications of the duodenal diverticula.
Such as
Obstruction, bleeding, perforation, pancreatitis, cholangitis, and recurrent common bile duct stones.
so let's say a woman has recurrent cholangitis despite cholecystectomy. You would suspect something structural rather than a stone is blocking the biliary duct or the ampulla, right?
Yes, exactly, because removing the gallbladder would fix the issue if it was due to a stone. But since this patient still had cholangitis after the cholecystectomy, think of a structural defect like a periampullary duodenal diverticulum.
We need to remove the duodenal diverticulum if it's symptomatic because we can't risk the liver and pancreas, right?
Of course, but be careful. Surgery is reserved only for cases with complications. We don't do surgery for incidental findings.
Now, let's switch gears to a condition that's a bit different to the last few, and that is SMA syndrome, superior mesenteric artery syndrome.
Superior mesenteric artery syndrome occurs when the fourth part of the duodenum is compressed between the aorta posteriorly and the superior mesenteric artery anteriorly.
And why does that happen?
If someone loses the fat pad cushion between the aorta and the SMA, most commonly due to rapid weight loss, that would make the angle narrow.
What about imaging?
An upper GI series shows a sharp cutoff at the fourth part of the duodenum, sometimes with a proximal dilation.
That should be good enough for SMA syndrome. Let's talk about short bowel syndrome.
Short bowel syndrome occurs when there is insufficient bowel length to support the adequate nutrition. The severity depends on how much bowel is lost, which segment is lost, the reason for the bowel resection, and the adaptive capacity of the remaining bowel.
Removing how much of the bowel usually causes issues?
We usually refer to losing about 80% of the small bowel. Patients who only have 200 centimeters left of the functional bowel are at high risk.
Is any specific part of the bowel more problematic to remove?
The ileum is quite significant in this context. Complete ileal resection is usually poorly tolerated. Since the ileum is very important, patients with only 30% remaining bowel but still have their terminal ileum may actually achieve acceptable nutrition despite having so much removed.
So if the terminal ileum is preserved, patients do better. But why is the ileum so important?
It has the greatest adaptive potential and plays a major role in the bile salt and vitamin B12 absorption.
Let's talk about some causes that lead us to resect some of the bowels in the first place, and let's separate them into adult causes versus those in children.
So in adults, the most common causes include mesenteric ischemia, Crohn's disease, trauma, strangulated hernia, neoplasms, volvulus, portal vein thrombosis, and radiation enteritis.
Okay, that was adults. What about in children?
In children, the major causes are necrotizing enterocolitis and congenital intestinal atresia.
After you remove part of the bowel, the remaining part has to adapt. How does it do that?
We have two types of adaptation, and those are structural and functional adaptations.
Let's start with structural.
Structurally, the remaining bowel increases its absorptive capacity by increasing the surface area available for absorption. So it increases bowel caliber, increases villus height, increases anterior side proliferation, and the crypts become deeper.
So it physically increases the surface area for absorption. What about functional adaptations?
Now, functionally, several changes occur to slow things down and maximize absorption. There is hypergastronemia, increased gastric acid secretion, and slower gastric emptying. The colon also plays a big role in increasing absorption of water and electrolytes, especially in the right colon. And carbohydrates are degraded into short-chain fatty acids, which can be absorbed and used as an energy source.
And as we said, the terminal ileum is really good at adapting to all these changes, right?
Exactly.
Now, let's get into the complications where we'll see malabsorption as a common theme. But is there anything else we should worry about?
One major issue is gastric hypersecretion, which worsens diarrhea and malabsorption, especially early on.
What does that have to do with removing bowels?
It's because parts of the small bowel normally play a role in inhibiting gastric acid secretion. So if you remove those, you're losing the suppression and gastric secretion goes crazy.
These patients can also get gallstones?
Yes, cholelithiasis occurs usually due to ileal resection because of altered bilirubin metabolism, decreased bile salt uptake, and chronic use of TPN.
That's not the only organ that forms stones in these patients. They may also get kidney stones, but why?
This relates to hyperexalluria. Normally, intraluminal calcium binds oxalate and takes it with it into the stool. In short bowel syndrome, the fatty acids we have in the lumen, which were not absorbed, will bind calcium instead. So now calcium cannot bind oxalate. So the oxalate gets absorbed into the body instead of going to the stool. And now it goes through blood all the way to the kidneys, leading to oxalate kidney stones.
These patients not only end up with gastric hypersecretion, gallstones, and kidney stones, but they may also get diarrhea and steatorrhea.
Diarrhea occurs due to rapid intestinal transit, where the food content does not stay in the lumen long enough to absorb water and ions. This leads to hyperosmolality of small bowel content, which pulls even more fluid into the lumen, leading to diarrhea. The steatorrhea occurs because of disruption of enterohepatic bile acid circulation, leading to fat malabsorption. This is especially true if we resect the ileum.
If you remove the ileocecal valve, all the bacteria in the colon may travel into the small bowel and cause trouble, right?
Yes, this is what we call bacterial overgrowth. Loss of the ileocecal valve allows reflux of colonic bacteria. These bacteria impair digestion and absorption even more because they compete for nutrition, alter pH, and deconjugate bile salts. Because of the bacterial overgrowth, they may get infectious diarrhea, which is a major cause of morbidity in these patients.
Those are a lot of complications. Is there anything else we should worry about?
Yeah, absolutely. Take care of anemia, coagulopathy, osteoporosis, liver dysfunction, TPI related complications, central venous catheter complications, and GI issues like fistulas, strictures, and bowel obstruction.
Uh oh. How do we manage them? We do it over certain phases, right?
Yes, the first phase of management is the acute phase, which usually involves the first 4 weeks. The goal is stabilization of metabolic, respiratory, and cardiovascular parameters.
So we make sure the patients are stable. How do we do that?
We basically rely on TPN to meet caloric needs, strict intake and output monitoring to assess dehydration, close electrolyte monitoring and correction, early enteral nutrition via feeding tube to keep the bowels awake, and proton pump inhibitors to reduce gastric hypersecretion and protect against peptic ulcer disease.
How does a feeding tube help? Shouldn't we give the bowels some rest?
We need to keep them active so they don't lose their function completely. Enteral nutrition has a positive trophic effect on the bowel mucosa. It stimulates the remaining intestine, improves immunity, and decreases infection risk. But you're right, we shouldn't overwhelm the bowels by giving them too much. So the feeding should be gradual, continuous, low volume, low fat, and isosmotic. They may not meet full caloric requirements at first, and that's okay.
After managing the acute phase, we go to the more long term phase, which is the maintenance phase.
This phase focuses on long term nutritional goals and supports the adaptation process over 1 to 2 years. Patients require supplementation with vitamins, trace elements, minerals, essential fatty acids, fat soluble vitamins like A, D, E, and K, vitamin B12, and calcium. You're giving them everything they can take in very well on their own.
Is there anything else we can do other than nutritional support?
Yes, obviously. We should manage any specific complications they have developed. We also sometimes give growth hormone and glutamine to improve adaptation, especially in patients dependent on TPN, where we can't give them tube feeding for whatever reason and need an alternative to keep the bowel awake.
Are we going to try to slow down the diarrhea?
For sure, we have some options like H2 receptor blockers, cholestyramine to bind bile salts, somatostatin analogs, atropine, diphenoxylate, low-dose narcotics like codeine or opium, and antibiotics such as metronidazole or tetracycline for bacterial overgrowth.
Can we do surgery to make some parts of the bowel bigger to compensate for the loss?
Surgery is the last resort. Some options include intestinal lengthening procedures, such as Bianchi procedure, serial transverse enteroplasty, aka STEP, tapering, or plication, and in severe cases, small bowel transplantation. It will be kind of difficult to explain all those fancy surgeries without drawings, so I suggest you look up some diagrams if you really want to understand them better.
We've really dissected the short bowel syndrome. How about we move to blind loop syndrome?
This is also known as small intestinal bacterial overgrowth, or SIBO, which we kind of brushed over in the last part. It occurs when bacteria proliferate excessively in the small intestine due to stasis, echlorohydria, motility disorders, loss of the ileocecal valve, fistulas, or IBD.
Remember, bacteria are normally in the large intestine, not the small. You said something about a chlorohydria?
Yes, without gastric acid going into the small bowel, bacteria are not suppressed, leading to overgrowth. It's like you lose the stomach's protective role.
Let's say a patient presented with long term PPI use, bloating, diarrhea, and B12 deficiency. This is probably SIBO. Let's break down each one of her complaints.
She had long term PPI use, which led to a chlorohydria that promoted bacteria overgrowth. Bacteria compete for vitamin B12 and deconjugate bile salts, causing malabsorption and B12 deficiency.
Now, let's briefly go over another disorder small bowel ulceration.
So, this may be due to NSAIDs, steroids, vasculitis, Crohn's disease, infections like TB and typhoid, lymphoma, gastronoma, and Meckel's diverticulum. They may also be idiopathic, and those are usually single, located in the terminal ileum on the anti-mesenteric border, and may progress to fibrosis and strictures, sometimes requiring resection.
There's not really much else to say about small bowel ulceration. We do, however, have another disorder that sounds pretty scary pneumatosis, cystoides, intestinalis.
Pneumatosis cystoides intestinalis refers to the presence of multiple gas-filled cysts within the bowel wall. These cysts can be located in the submucosa or the subserosa.
And visually, this is where those classic images come in.
Exactly. You see this characteristic honeycomb appearance where multiple round, air-filled spaces are seen within the bowel wall. The cysts can range from microscopic to clearly visible macroscopic cysts.
Which part of the bowel is most commonly affected?
Pneumatosis cystoides intestinalis is more commonly seen in the duodenum.
And how do these gas cysts form?
The gas within these cysts is mainly hydrogen gas, which is produced when anaerobic bacteria ferment carbohydrates. The gas within these cysts is mainly hydrogen gas, which is produced when anaerobic bacteria ferment carbohydrates. This gas then dissects into the bowel wall, forming cyst-like collections. There's something interesting, which is that pneumatosis cystoides intestinalis can occur in patients with impaired pulmonary function. Since these patients have a reduced ability to get rid of hydrogen gas through their lungs, the gas accumulates within the intestine and starts to get into the wall.
So it may be secondary to other conditions?
Yes, secondary pneumatosis cystoides intestinalis can be seen with inflammatory bowel disease, steroid use, infectious gastroenteritis, diverticulitis, leukemia, and lymphoma, immunosuppressed states, including AIDS and chronic obstructive pulmonary disease, or COPD.
So in many cases, it's really a reflection of another disease. But can it also be idiopathic?
Yes, we would call it primary pneumatosis cystoides intestinalis. This is less common than secondary cases. This form is idiopathic and is usually limited to the left colon.
How do patients with pneumatosis cystoides intestinalis usually present?
Symptoms are often nonspecific, and primary pneumatosis symptoms may resemble irritable bowel syndrome, such as bloating or abdominal discomfort.
And secondary cases?
In secondary pneumatosis, symptoms are usually related to the underlying condition, rather than pneumatosis itself.
This condition already sounds scary by itself, but are there any complications we should worry about?
If the gas-filled cysts rupture, they may lead to pneumoperitoneum, where the air goes outside the bowel and into the peritoneal cavity.
Alright, finally, our last topic for today's episode is enteric fistulas.
Yes, an enteric fistula is defined as an abnormal communication between two epithelialized surfaces like two hollow organs or between a hollow organ and the skin.
What is the opening caused by?
The most common causes are surgical complications, including anastomotic leaks, iatrogenic injury to the small bowel, erosions by synthetic mesh, retained surgical sponges, and erosion caused by intra-abdominal suction drains or catheters.
But they aren't always surgical, right?
You're absolutely right. They may be due to Crohn's disease, trauma, and diverticulitis.
Why can't the opening just close on its own?
There are sometimes some factors that interfere with the spontaneous closure of the enteric fistula. We actually have a mnemonic to help you remember them.
Oh, yes, Afnan, the mnemonic was his friends. Each letter stands for something. Let's go through each letter one by one.
Okay, let's break it down. H stands for high output fistula, meaning large daily fluid loss. I is infection. S refers to short segment fistula. F is foreign body, such as mesh or sutures. R stands for radiation. I again for inflammation, A for epithelialization of the tract, N for neoplasm, D for distal obstruction, and finally S for sepsis.
So, if these are present, the fistula is unlikely to close on its own, right?
Exactly.
Okay, what about complications of fistulas?
Enteric fistulas can cause significant fluid and electrolyte depletion, leading to dehydration, metabolic disturbances. Malnutrition is also a major complication due to ongoing nutrition loss.
If I remember correctly, there are also skin complications.
You're absolutely right, Hanin. There may be local skin irritation and breakouts, skin necrosis at the fistula drainage site, and of course, sepsis, which can ultimately lead to death if not managed appropriately.
How do these patients usually present?
These patients may initially present with a walled off abscess or with a wound infection. The initial discharge from the fistula may be pus or blood.
Okay, how do we classify fistulas?
Fistulas are classified based on location and based on output.
Let's start by defining output.
A high output fistula produces more than 500 cubic centimeters in 24 hours. A moderate output fistula produces 200 to 500 cubic centimeters per day. A low output fistula produces less than 200 cubic centimeters per day. A low output fistula produces less than 200 cubic centimeters per day.
That classification directly affects management decisions, right?
Exactly. Managing a fistula with more than 500 cubic centimeters output is not the same as less than 200 cubic centimeters.
Okay, you said managing a fistula. How do we even manage them?
The management approach begins with characterizing the fistula, which includes defining its location, output, and cause.
Then the priorities?
First is skincare to prevent further breakouts, then control of sepsis, which may require antibiotics and drainage of abscesses.
And fluid balance?
Fluid balance is very important. We need to provide fluid and electrolyte replacement, followed by measures to decrease fistula output.
What about nutritional management?
Patients are usually kept MPO, and total parenteral nutrition is initiated to support healing and prevent malnutrition.
We should also address any underlying cause.
Yes, whether it's infection, inflammation, or obstruction that is maintaining the fistula's patency, we need to fix that.
Does surgery come into play?
Surgery is considered only after stabilization, and when conservative measures fail or when the fistula is unlikely to close due to factors like those in his friends.
Alright, everyone, we're almost done. Let's wrap this episode up with a quick recap.
Sounds good to me.
We began with Meckel's diverticulum, the most common congenital anomaly of the GI tract.
It's a true diverticulum located 2 feet from the ileocecal valve on the antimesenteric border of the ileum, often containing ectopic gastric mucosa, which explains the classic presentation of painless bleeding in young children.
And of course, we can't forget the
Rule of twos. 2% incidence, 2 to 1 male predominance, presentation before the age of 2, located 2 feet from the ileocecal valve, about 2 inches wide, and containing 2 types of mucosa.
Then we moved on to the small bowel diverticula.
These are rare, acquired, false diverticula, more common in the duodenum arising from the mesenteric border, and they often cause symptoms through bacterial overgrowth, leading to malabsorption, inflammation, or obstruction.
Next were duodenal diverticula, which are actually much more common than people expect.
Yes, most are asymptomatic, usually periampullary, and can cause serious complications like pancreatitis or cholangitis. A surgery is reserved only for complicated cases, not incidental findings.
We then switched gears to superior mesenteric artery syndrome.
This occurs where rapid weight loss leads to loss of the fat between the aorta and SMA, compressing the fourth part of the duodenum and causing sharp cutoff on imaging.
Then we talked all about the short bowel syndrome.
It results from loss of about 80% of the small bowel, with severity depending on how much bowel is lost, the adaptive capacity of the remaining segment, and which segment is resected, especially if it was the terminal ileum.
We also talked a lot about adaptation.
Yes, we did, structurally through increased surface area and functionally through hormonal and motility changes, with the colon and the terminal ileum playing a major compensatory role.
Then came the complications,
including gastric hypersecretion, gallstones after ileal resection, kidney stones from hyperoxaluria, and broad nutritional deficiencies due to malabsorption.
Diarrhea and steatorrhea were also major themes,
driven by rapid transit, bile acid loss, and bacterial overgrowth, especially after loss of ileocecal valve, leading to infectious diarrhea and further malabsorption.
Management was divided into phases,
starting with acute stabilization using TPN, electrolyte correction, PPIs, and early enteral feeding, followed by long-term nutritional support, complication management, and surgery only as last resort.
After that, we covered blind loop syndrome.
Also known as SIBO, caused by stasis or eclarohydria, leading to bacterial competition for nutrients, bile salt deconjugation, and vitamin B12 deficiency,
We then briefly discussed small bowel ulceration.
which can be due to medications, inflammatory disease, infections, malignancy, or idiopathic causes, often affecting the terminal ileum and potentially progressing to strictures.
Then came one of the scariest sounding diagnoses, Pneumatosis cystoides intestinalis.
Characterized by gas-filled cysts in the bowel wall, usually in the jejunum, often secondary to other diseases, and sometimes causing pneumoperitoneum.
Finally, we wrapped up with enteric fistulas.
Abnormal communications, often caused by surgery or Crohn's disease, complicated by fluid loss, malnutrition, and sepsis, with closure heavily influenced by these friends factors and management focus on the stabilization before surgery.
And with that, we wrap up miscellaneous disorders of the small bowel. Thank you all for listening to PodBites. We'll see you in the next episode.